Welcome, ladies and gentlemen, to the Monday evening Royal College of Surgeons of Edinburgh webinar show. This evening, we are going to discuss with three eminent panelists from Africa and the Middle East about the influence that this pandemic has had in their respective countries. The current pandemic has impacted and changed lives on a global scale since its emergence. It has caused millions of infections and thousands of deaths worldwide. The spread from the east to west has almost been a tidal wave, and to control this virus still appears to be unachievable in many countries due to inadequate resources, albeit healthcare or fiscal. This evening, we have Dr. Faisal Alam, a senior consultant vascular and general surgeon, who is also a lead examiner for the Royal College of Surgeons of Edinburgh from Muscat in Oman. We have Professor Eric Borgstein, who is a professor of surgery, University of Malawi College of Medicine, and he's a consultant pediatric surgeon at the Queen Elizabeth Central Hospital in Blantyre, Malawi. The third panelist is Mr. Ahmed El Said, who is a consultant cardiothoracic surgeon with a big interest in education from the Al-Shab Hospital and Al-Azain Al-Azhari University in Khartoum, Sudan. I would like to welcome all of you on behalf of the Royal College of Surgeons of Edinburgh. They will inform us of their experiences of dealing with the pandemic in their countries with specific impact on surgery, medical education, and strategy of returning to near normal. Thank you very much, gentlemen. I would now request Faisal to get started, following which Eric and Ahmed will make their presentations. At the end of this presentation time, we will have at least 30 to 40 minutes of discussion, during which time I would like a lot of questions to come into the chat box, please. The interesting pre-meeting chat that we've had has been on delivery of training, delivery of education, and examinations. And I hope that we will have a very vibrant discussion today on that particular aspect. Thank you. Faisal, can I request you to please make your presentation?
Thank you very much, Mr. Rajesh, for the invitation. And hello, everybody. I'm going to speak about how Oman's response was in regards to this pandemic. Waiting for the slides to come up. Yes, there we are. Right. In Oman, of course, as you all know, we have been waiting till the WHO announced the situation that this virus is pandemic, the COVID-19 thing, on the 11th of March. And immediately on the same day, His Majesty has announced for a Supreme COVID-19 committee to be formed, and which had their meeting on the first day itself. And soon they have taken immediate actions for the country lockdown. And this was, the lockdown involved schools closure, and mosques were closed as well, and travel restrictions. Nobody was coming into the country. Only people who are going out of the country were allowed. Those who are coming into the country later on were allowed, but with the provision that they will have to undergo 14 days quarantine, institutional quarantine. Universal precautions, of course, and social distancing, which were taken everywhere in the world. Staff working hours in all the offices have been reduced to 30%. People those as much as possible who can do from home, they were allowed to do work from home. So this was in general what in the country what the decisions were taken. Healthcare capacity building, routine admissions were cancelled in the hospital. So immediately that all the routine operations and routine admissions and routine clinics also were cancelled, and they were all downgraded. Apart from cancer cases, of course, they were taken as case by case, like they were prioritized according to what cancer cases are there. Clinic visits reduced to minimum. Most specialized clinicians were trained in how to handle ventilators and emergency patients. A lot of surgeons were involved as well, like they were asked to go for training to handle the ventilators in case of overflow of patients. And our colleagues in the emergency or the anesthesia, they get overwhelmed. Sections of the hospital were allocated for COVID-19 patients. A lot of wards have been changed into COVID-19 admissions only. That involved our surgical wards as well. The effect on the surgical services in particular, of course, reduced bed capacity. We only had one ward with 28 beds for male and female together. And routine surgeries, as we said, cancelled, and there were only 3 theaters. One is for 24-hour emergency theater for emergency cases only, and then 1 theater for the cancer cases, which cannot be delayed, and then 1 theater specifically for patients who are COVID positive and needing surgery. The anesthetists are overwhelmed, and that has had a major effect on the surgeries. Even for the emergency, they were delayed in getting the patients in the theater, of course, and waiting time for emergency cases prolonged. Surgeons were redistributed to assist in COVID-19 wards, and that has impacted on our on-call rotations also, surgical on-call rotas. Surgical training was stopped initially, and later on, after about a month or so, when the situation was slightly under control, then the decision was that they should be allowed to, but then with particular isolation and protection from the PPEs to be worn according to the situation. All hospital CME sessions and multidisciplinary meetings were cancelled. Conferences were cancelled as well. The situation, I mean, initially, of course, the closure was for 1 month, and then it had to be extended because of the continuation of the problem. And we had this month of Ramadan in aftermath of this pandemic, like in the month of May, where the situation started to escalate a little bit because of the people started to visit and started to make gatherings, especially in the final days of the Ramadan. And there the situation got more into difficulty actually because of increased number of patients in the ICU, and then we didn't have ICU beds as well. And so that impacted on our emergency surgical cases also, to find a lot of patients needing ICU beds. We were not able to provide ICU beds for them. Measures taken to get back to normal. Masks were made as a must for everyone who is entering the hospital, including the patients and the staff. Emphasis on virtual clinics. clinics these were started soon after, about a month after the pandemic. We started to get into the virtual clinics, and it was well received with the patients as well. They were because a lot of patients, they didn't want to come to the hospital because of the pandemic. And so this was one of the things which we are continuing to do that, even it will have its impact on even post-pandemic, most likely. Utilization of regional hospitals for some operations. This was, again, very helpful because there were some majority of the patients, because of the population distribution, was in the capital and also in the northern part of the country. But there were some other regions where the situation was not that bad, and we had these regional hospitals where a lot of patients from Muscat could have been transferred there for procedures. Fast COVID-19 test for staff if they have symptoms. Those who do not have symptoms continue to work with precautions. And even with the mild symptoms or something, like if it's very mild and everything, because of the lack of overwhelmed staff, and because of lack of staff as well, they had to continue working with precautions. Cancelled routine lists are rescheduled according to priority, and still we have this routine list is becoming ever increasing in size, but they are rescheduled according to the priority, of course. Seminars and conference rooms are marked with maximum. So we are doing some seminars and conferences, but then, not basically seminars within the hospital, like CME, continuous medical education, but all the rooms are marked with maximum number of people allowed in the room. So there will be rooms which are probably allowed only 8 people or 10 people maximum. So all the rooms are marked. Surgical residents are back in their rotations at the moment. Residents, they're teaching as much as possible. When there is some teaching session or something, these are done online. So everybody is getting into Zoom app, and it's all mostly now delivered online, actually. There's no meetings happening together in gathering. These are the main issues, main things, and our strategy for trying to come back to normal. And I hope I didn't cross the time I was given. So this is in simple what the situation is in Oman. Thank you very much.
Thank you very much, Faisal, for giving us an overview of what you have been doing in Oman. I would now like to move to Eric to give us his experience with COVID in Malawi. Over to you, Eric.
Yeah, I'll just get the presentation up. So in Malawi, just to set the scene a bit, we're way down near the bottom of Africa, but here's the overall picture of Africa. Overall, the pandemic reached us much later than the other continents and has been taking much longer to peak, as it were. And so far, we've had nearly 1 million recorded cases with an overall mortality of 2%. Malawi is a small landlocked country, and in a way that's protective because there isn't that much traveling, and you can see that the hotspots in Malawi are the 2 big cities, as it were, areas, and then some of the areas which have either border traffic or have a high migration of people to South Africa. South Africa had far worse has had a far worse time than we have so far, and South Africa employs migrant workers from all over the continent. And when they started locking down, all the migrants came home, and that's when really the virus peaked or started to increase in Malawi. So we the first response in this country was to close the schools and have a sort of partial lockdown. And for a month or two, very little happened. As you can see on this graph, that for the, from March and April, nothing. And only in May, June did numbers start increasing. But the death rate still is fortunately still very low. This is the actual cumulative trajectory in Malawi over 140 days, and you can see we're slowly gaining on the peak. But if you compare that to the curve in South Africa here, then on the bottom line here are Malawi, Zambia, and Zimbabwe, all with a much lower increase so far. Whether will stay that way, we have to wait and see. So far we've had about 4,000 cases and just over 100 deaths. And the Ministry of Health puts out a regular bulletin telling, giving updates and advice and producing statistics which show, how the doubling time is increasing, and a lot of that is, initially was, but there were just a few imported cases, then there were large numbers of repatriations, and then we started seeing community spread, and that's where we are now at the moment, that community spread is really on the increase. And if you compare the numbers in the different countries, and the different response does have an effect. Mozambique, with a very strict lockdown, has lower numbers. Zambia, which still has international flights and has far more traffic, has a higher number. So what was the response? Well, initially, of course, when everything started, there was huge panic about what to do, because of, we have a healthcare system which is overstretched at the best of times, and there was shortages of PPE, and there was a lot of fear. There was striking health workers, and it was quite difficult to keep the show on the road, as it were. The ministry did make lots of provision and decided that patients wouldn't be kept in hospital, but in special places. But none of that worked terribly well. In the surgical departments, we managed to, get PPE in place and develop pathways for treating the patients. And to be honest, to date, I think we've had 2, proven corona positive patients who required surgery. So it's not as if there are large numbers needing surgery, but there are, of course, far more patients who do require hospital care. And one of the early things we did as well was to introduce, oxygen generating plants, which were assembled really very fast. And so before the numbers started increasing and we started getting our peak, we did have adequate supplies of oxygen in our hospital available. So the priorities for us was initially to make sure the staff were protected, then to reduce the numbers of inpatients by reducing elective numbers, and then but keep as much as possible, keep emergency surgery going. The limitations in our system are very, as I said, we're a health system which can, struggles to cope at the best of times, and the limiting factor really on expanding any care or providing any care is anesthesia, and with the the necessity to provide more intensive care, to provide oxygen, the anesthetic colleagues are really spread very thin indeed, and that's had a severe impact on the ability to provide the emergency surgery and the and even keep a degree of elective surgery going, particularly in urgent cases. We have, in a hospital with 1,800 patients, we have 4 ICU beds for adults. And you can imagine that ramping that up, has not been easy. And we've had to designate special wards and special equipment for COVID victims. We have established the practice of working in teams so that not everyone's in the hospital at the same time, so that some of the healthcare workers are protected. I think one of the things to remember for a country like ours is that, of course, as surgeons, we have been working within the context of an existing pandemic. The HIV pandemic isn't over by any means. There are still, high infection rate. There was still a high number of patients around, and so we have been in the past and still now we have been working in the context of a pandemic before, but we do have the lowest number of healthcare workers per head of population in the world almost, and a very underfunded health service. So there's not much room, and once you start diverting money to cope with a crisis like Corona, then the rest of the health service obviously will start to suffer very rapidly. And so we've realized that the growth of the numbers has been really quite slow and is likely to continue for much longer. We're not going to have a very acute peak. We're going to have a long growth and then probably a plateau, and we have to accept that it's here to stay and that we have to learn to work around it and with it, and that we have to try and mitigate the effects on the health systems and the health service by finding ways to continue to carry out elective and emergency surgery. And we're now at the stage where for the last 2 months we've really not been able to do much elective surgery, and we really want to start increasing that now. And we would like to test our patients if we could, but the numbers of tests available are very limited, and the vaccine is going to take time. So that's the situation in Malawi, and I just wanted to comment really from the focus of the College of Surgeons of East, Central and Southern Africa, COSEXA, that a bit in the same way as Rajesh was saying just now, there's a serious impact on training. Our trainees are not getting the surgical exposure they otherwise might. We've had to postpone examinations, we've had to move to online examinations, and we've had to make all kinds of plans. We've had to shift our timetables, and it's been hugely disruptive for everyone, and I'm sure that's the same, very much the same in the UK as it is here. Thank you.
Oh, you're muted, Raj, sorry.
I think the fact that your health system has been underfunded, but the fact that you have only 200 deaths and you've had less than 5,000 patients in the whole of Malawi is extremely creditable. I'll bring some of the questions I have during the discussion. I see that there are already 7 questions, and we have almost 90 people on the participant list, which is excellent. Ahmed, over to you, sir.
Okay, well, thank you very much. First of all, I'd like to thank the College of Surgeons for allowing us to share our experience. And when I saw the timetable and I was following Eric and Faisal, I thought it would make my job much easier, because I think they've said most of what I'd like to say, especially Eric, with Malawi being pretty much in the same league as Sudan, I'd say. So what have we done in Sudan? First of all, my presentation, just to set the background for it, is first of all, Sudan, for those of you who do not know it, is there. We like to say in the heart of Africa. The heart, unfortunately, has been opened, so we're 2 Sudans now, as you can see there. So now, one of the interesting things that I found when this pandemic came over is that maybe we as clinicians do not know a lot about public health. Maybe it's because the public health guys, we don't go to the journals, but what we're seeing now is something that has been happening. There's 10 pandemics that have happened. If you look at the data, the nice graphs we're getting was seen in the bubonic plague in London over there. So it's something in history we should have learned of, and it's maybe a lesson to us clinicians is we should get out of the hospitals a bit more and see the wider realm of medicine. Now, what is the status quo in Sudan? Our numbers are there. The total cases we have are about 10,000 to date. These are the active cases and the total death that we've had since the 12th of March when it first started. As you can see, we think they've started to plateau, but we're very worried, and I'll tell you about that in a minute. And these are the daily new cases over there. So looking at figures from this perspective, it looks that we're doing well. We have plateaued with number of cases and death, and although we're just over 10,000, although our amount of deaths are horrendous by any stroke of the imagination, 800, but I'll come to that, why we think that happened. So now the normal preventive measures, this Batman here is what is happening in the world. As you can see, Batman is practicing social distancing and wearing his mask over there, but this is social distancing in Sudan. Remember, we are a country in Africa. Something like this affects the economy. When you affect the economy, you get a lot of other problems. So these are people queuing for bread, would you believe? No social distancing. You have their backs, but I can tell you, because this is around the corner from my house, nobody wears a mask. All of the masks, by the way, have like, the price of a mask has gone by 5,000%. So nobody wears it in the general population simply because they cannot not afford it. So really, yes, we did do the preventive controls, the mask and the social distancing, but I think we were kind of kidding ourselves on how good. I do not go out of the house for 2 months, but my sons, they go and get the bread, and this is what they see, and these are the pictures they come back with. So not a lot going out there, let's say, especially among the lower class of the population, let's say. But like Faisal and like Eric before me, our first case was on the 13th of March. Immediately, 15th of March, we had a partial lockdown from 6 a.m. to 6 p.m. And unfortunately, all non-essential surgeries were stopped. And worse is all house officers, because supposedly under training, were told to stop work, and that impacted our health system immensely. There were no protocols for what is non-essential surgery, and I'll come back to that in a minute. There's no protocols, so basically, most of hospitals stopped everything, except for dire emergencies, let's say, and that is what increased our mortality. My hospital is a cardiac hospital. Basically, we lost 50% of our heart failure patients. They would go from hospital to hospital, nobody would see them, and in the end, they get an infection, and you query COVID. There was not a lot of testing at the time in Sudan, and they would die, basically of pneumonia, I'd say, or fulminant heart failure. Now, we did a study, COVIDOR, and I'll come to that in the next few slides. COVIDOR is a study we want to do in 12 African countries to see is what is happening the same. And we did get approval from 12 surgeons, mainly cardiothoracic surgeons like myself all over Africa. But unfortunately, another of the problems in Africa, we could not get ethical approval. We only got ethical approval in 4 countries. And those are the ones that went in the study, which I'll show you in a minute. But pretty much the same as what we were saying. To continue with the country, the lockdown was extended until mid-July, when it was partially lifted. Now, that was quite clever of the government, because, end of July, we have our big Eid holiday, kind of like the biggest festival for us in the Muslim calendar. And nobody works, by the way, and we're still not back to work. We're supposedly back to work tomorrow, but our bet is nobody will be back before Sunday. It's a time of year that people take a long break out of work. So effectively, although the government said you can start electives, very few hospitals did start. Some of the few regional hospitals started, but not all of us. And we're quite worried about these decisions. Now, coming back to the COVIDOR that we did to get a perspective of what's happening in Africa, we managed to get 82 surgeons from 4 different countries, quite representative of let's say, East, West, and South. 89% of them were male. 34% of them were general surgeons, but there's quite a spread. Urologists came second, cardiothoracic surgeons, my friends basically came, and we looked quite closely at the spread of where they work. 38% of them were in the public, 13% were in private, and 50% were both in private and public. Now, we like to see this because, you see, the dynamics of what happens in the public are different from what happens in private. Public, it's an obligation. You get paid so little money that it's an obligation. It's a public service. But the private sector is where you make your money, where you live basically as a surgeon. So when we looked at it, more than 95% of the surgeons in the public sector stop their work, complete their elective operations. We're looking at the private sector, only about 60%. So there's a substantial minority who are still working. The orange, by the way, are the ones who are not working in private. And when we looked at, does your hospital have a protocol? Remember I said about elective surgeries? Well, so private or public, only about 50% had a protocol of what would you define as a non-elective, urgent, or emergency surgery. So these are things which really, I think, impacted quite a lot on the emergencies are emergencies. We're not talking about those. I mean, if we look at me in the cardiothoracic domain, aortic dissection is an emergency. But what's about evolving infarct? Where that is urgent, it needs to be done, but you can get away with medical treatment sometimes, but surgery is much better. So where does that fit? No protocols. Basically, the surgeon decides, and in most cases, in the public sector, they do not do them. The patients get, that's why our mortalities are high. Then we looked at personal protective equipment. Well, about 60% of private or public hospitals did have personal protective equipment. But then look at this. When we ask, is the personal protective equipment enough for all the staff? It's good enough that the surgeon has PPEs. But what about his scrub nurse? What about the porter who brings the patient over? Well, you can see there in the public sector, 80% of them thought that there was not enough to go around. Again, that stops you doing work because basically, if anybody in your team is not protected and he refuses to work, well, your work stops. And same applies to the private sector is a bit better. So they're about 51% of all the staff do have their PPEs. So, and then we looked at, does your hospital have an ICU? Well, 85% do have ICUs. Now, what is an ICU? I leave that, but let's say that they do have an ICU. But then let's come to this. Do you have masks to use in the hospital all around? Not the operating room. Just when you're seeing your patients on your own, only 50% of them have enough masks to be used inside the hospital. Do you have a rationing policy? i.e., if somebody is dying on a ventilator, are you allowed to take them off? Is there any policy? No. The majority do not have. A disaster policy, a bit better. 50% of them do have a disaster management policy. And that, I say, the disaster management, I think that's mainly because the WHO has been very strong in this, in the Afro and the EMRO regions. Then we asked the participants themselves, where did you learn PPE? Well, by himself or from YouTube. Only about 10% was there something given by the hospital or the higher authorities to show him how to use PPEs. And worse still, only about 40% could manage a ventilator. And then in their personal life, 25% do not practice social distancing, and surgeons, 10% do not wash their hands regularly. So we're not setting a very good example, I must say, to the population in general. And you can understand if 25% of us are not doing social distancing, well, what happens to the general population? So back to Sudan. As of the 4th of August, like I said, we'll be back from Eid holidays, and we should be starting work. I don't think we will be. I think it'll be the 9th of August, but we have problems. Khartoum, our capital, where like 30% of the population resides, and where we've got the bulk of cases, is still closed off. You cannot move into it from the other provinces. Patients are very apprehensive. They do not social. We're doing a big study on stigma of COVID. And believe you me, it is a stigma as far as, in fact, it's even worse than mental illness, which was our biggest stigma before that. So we're really uncertain is if we will be going back to it. Some of the provinces, I must say, have started their work since before the Eid holidays, and they have a big waiting list now. But for the country, we wait and see. And what is worrying for me is this graph here. Now, this is the MRC, the Medical Research Council, predictions, but our own modeling here shows the same thing. If we maintain the status quo, we will be going on a downward trajectory, as you can see there, not very steep. If we increase what we're doing by an additional, so if we increase our social distancing on our masks and all washing hands, we should by the end of August have overcome it. But if we stay as we are now, But what is worse, I don't think we're going to stay as we are. We're going to relax. So see what will happen if we relax. So it's with a bit of trepidation that we're looking forward to what will happen. So now, I just want to say, what are the lessons we learned? Now, the lessons we learned, number one, health is not just clinical. As you can see there, clinical work, medical care is only about 10%. Remember, we were always taught this in medical school, the social determinants of health. Well, our clinical work is only 10%. There's a lot of other factors, and COVID has shown us that lesson very badly. So your personal behavior, your genetics, your personal behavior, your social circumstances are much, much more important than the clinical care, which is only 11%. So for us in Africa, our health systems, we have a problem. We have a big problem. The WHO recommends that. If we look at each one of those, we have a big problem as far as we're concerned in Africa. And biggest of those are the universal health coverage, the surveillance, the disaster planning, and the rationing, which we do not have. And the inequity that we have. And I'd like the colleague to take this up. You know, migration, shortage of physicians, and I think this covers a lot of the developing world, the shortage of physicians and medical staff, and how that is impact a lot of others, the information system, the low quality of care, the prohibitive costs, the corruption, are things that should be looked into. Each of these, I think, are a topic on its own for the college, but I'd like for us to start about the brain drain and migration and how we could all, as fellows of the college, look into this and propose solutions for it. And equity and equality. Now, we want equity. We want this side. We do not want equality. In our country, unfortunately, we have equality. But there's a lot of inequity because those who have money will get treated. Those who have power or prestige will get treated. We have to think of how are we going to have proper equity in our country. And this has been shown quite well. If you're in emergency and you have wealth, power, or prestige, you will get treated. Or you're in an urgent case, you will get treated. Prestige is, you know, some doctor who will treat you. You will get treated. Don't have any of those, even if you have an urgent case. Emergency, we should have done is, well, we tried our best, but I think now we know better. And if we know better, we really should do better. We should look at all these problems and see how we can solve them. And in the end, Mr. Chairman, ladies and gentlemen, I'd like to say that I like Peanuts and Charles Schulz very much. So this is a nice quote from him. We shouldn't worry about the world coming to an end today, because in Australia it's already tomorrow. So COVID has taught us a lot, and I think, thank you for listening.
Thank you ever so much for a fascinating talk, Ahmed, with a lot of data which you have spoken about with so much of honesty. I think, you know, I'm going to look at the discussion. We've already got 20 questions, but if I can kick off to all three of you, the R0 numbers are quite high in Africa. It's 2.37 in South Africa. What steps are being taken as far as testing, tracing, and, you know, cluster containment? Eric?
Well, it's limited by the availability of tests, but I think, you know, they're doing their best. We've done something like 28, nearly 30,000 tests and contract tracing. But, you know, the big problem is very much in the same way as Ahmed showed, you know, social distancing and lockdown doesn't work. You know, not that we have lockdown. In Malawi, lockdown was challenged in the courts and didn't happen, fortunately, because it's, you know, it would be economic disaster. But generally, you know, the social distancing doesn't work in very poor countries. So testing, tracing, and, you know, quarantining is, as everyone else is what we're doing, but on a, you know, more limited scale.
I have a further comment and a question from Michael Keatley to you, Eric. He says, having spent some time in South India in retirement, is his view about changing the pathways to conventional treatment in the peri-COVID-19 world? he discovered that there were different ways of doing things for elective surgery. He found that he did not need to admit many surgical patients to hospital for surgery, and there were many things he could do under sedation in a clinic setting. So his question is, how much can this experience change surgical practice in the West?
Well, interesting question. It's not really how we work here. I mean, Malawi has a quite reasonable health structure, so that operations can be done under anesthesia and can be referred from the smaller hospitals to the referral hospitals. So I'm sure there's an awful lot that could be done like that, but I'm not really the right person to answer that question, because I'm in a tertiary referral pediatric surgical unit.
Okay.
If you allow me there, Paula, I'd like to comment on that. When I first came back to Sudan in 1990 to do open heart surgery, because I was a general surgeon before that, in 1999, I tried to copy-paste the exact protocols that we're using in London. So I described my patients in 5 days post-open heart surgery. They all came back in 15 days with a massive infection. So we learned very early on that social determinants of health, their social circumstances, where is he going back to? Is he going back to a room alone? Is it clean? Will there be goats around him or donkeys or whatever? So I would not really encourage that for third world settings. For first world settings, it's something to ponder, I must say.
Thank you. Thank you very much. A question for Faisal from my colleague, Alistair Gibson. Oman has always provided some humanitarian care to Yemen. Is the border totally closed? And do you have any knowledge as to what is happening over the border? Faisal.
You're muted. Faisal, you're muted.
I can't hear you. Please unmute.
Yes. Can you hear me now?
Thank you. Thank you, Faisal.
All right. Thank you, Alistair, for the question. Yes, the borders are totally closed and nobody is allowed to get in. But of course, there are exceptions. Like, after about a month of the lockdown, a lot of Omanis who are studying abroad or working abroad, they were allowed to come in special chartered flights, providing that they are going into institutional or community isolation for 14 days quarantine. And specifically in the Yemen border, it's also applied the same thing. I don't know what's going on across the border, but then the usually, yes, you are right. They were allowed to come in for treatment, and especially in the southern part of Oman for treatment and because there are family bonds as well. But with this pandemic, the borders are closed completely. But special cases, of course, there will be that they're allowed in, but with the precautions as usual. I hope that answers.
Thank you. Thank you very much, Faisal. The next question is for Ahmed. The anonymous attendee says, when vaccines eventually arrive, what hope is there of it reaching the poorest in developing countries, given that developed countries are already buying up the vaccines before they're even fully developed?
Well, it's interesting you say that. We have a similar thing in cardiology with rivaroxaban, a very good drug, an anticoagulant, which is much better than warfarin. The short answer is there is no hope. We're thinking that the first world will have enough vaccines by the end of 2021. So we're looking at 16 months from now, and then maybe there will be some trickle over to us. But the way you look at it, and my analogy for that is, I don't know if you saw on the news the plane with masks that was somewhere in China and was hijacked, let's say, by the United States and diverted instead of going to Germany, going over to the United States. So I think as soon as the vaccine comes out, there will be even the sellers of the vaccine, the companies. If any country offers them more money, that's where the vaccine will go. Unfortunately, I think that the whole world is in panic. And this panic, I think a lot of it has been man-made, but it's the fact that we have to live with. So short answer is not till the end of 2021 as far as I'm concerned.
Thank you. Thank you very much. Eric, you talked about HIV is still, prevalent in Malawi. And you guys in Africa have had first-hand experience of Ebola, and the way that you dealt with it was amazing. So the question for you is that, are the deaths in Malawi in the elderly or just in those with underlying medical conditions? Again, from Alistair Gibson.
So it's early to say, but it does appear that the deaths are predominantly between 20 and 50 years of age. You've got to remember that we're a country with a median age of 17, and half the population is 15 and under. So the elderly are not particularly prevalent, but they are at risk. But it does seem that the virus is finding a niche in those with comorbidity, as expected. And right. Comorbidity being things like diabetes, and no one's, at least I haven't read anything definite yet about the patients with HIV who are on treatment. And some people say the treatment may protect, and others say they might be susceptible. So I don't think we know enough yet about that, but that's the situation at the moment.
Right. The next question. Sorry, Ahmed, go ahead.
Sorry, I just sent the name of, I forgot her the book. There's a doctor called Sinead Walsh, who's Irish. She's been a diplomat for the last 20 years. She's now the ambassador of the European Union to South Sudan. During the Ebola crisis, she was the ambassador of European Union to West Africa. And she authored a fantastic book. And now, there's a lot of lessons that came out of that. Now, lesson number 2 is the death from other diseases because of the lack of access to medical care were much more than the projected death of Ebola during the crisis. So South Sudan, beware. And that is exactly what we did not learn. We didn't know about it. We just knew about it after the pandemic. But the death, because of the lack of access to medical care, the deaths from our other heart failure, diabetes, hypertension, renal failure were much more than the projected death from COVID.
Mm-hmm. Mm-hmm. The next question is to all of the panelists from Joan Robertson. Does the team from Africa and the Middle East find that children are usually not affected? My add-on to that is children with malaria may not be given their medications because of the lockdown and the apprehension of going into hospital. What exactly has been your experience with this? If I can start with Eric and then move on to Ahmed and Faisal, please.
So, we've had a few children who've tested positive. I don't think we've had many who've been sick with corona. Mm-hmm. And certainly we haven't seen any in the pediatric surgical field. I think generally speaking, the routine medications for things like malaria are available so widely that they can be accessed without the patients having to get to hospital unless they're very sick. And I think we are managing to treat the emergencies and the sicker patients despite the sort of semi-lockdown. No, the worry is for the semi-electives and the things that that do need hospital care, but are not sick enough to get on the emergency train, as it were.
Right. Ahmed?
I would agree with that completely. We have yet to see, I think we've only seen about 10 positive children's cases and no death. And like Eric said, you don't need to go to a hospital to treat malaria here. Everybody mm-hmm. diagnoses it himself and gets the treatment off the shelves somewhere. But like Eric said, the problem is those in the middle. The heart failure patient who can be treated, but he gets a chest infection. And then his checklist for COVID is 6+. Those are the ones who lose out.
Right. Faisal?
Fortunately, it's very, very low in children. They are not getting that much. When the lockdown has eased down, the children up to 11, they were not allowed to go out of houses anyway, because I think the issue is probably they are very difficult to get them under control, most likely, because they are the ones who are spreading the virus most likely, but there are very few who are really getting sick.
Thank you. Thank you. Now, interestingly, this is from one of the attendees. In the UK, trauma cases reduced significantly during this pandemic. Is this the same in your countries? Have trauma cases reduced?
Yes, I would say definitely yes. We have a registry of trauma, and it has gone down by something like 70%.
Right.
It's amazing, you know. One of the silver linings, I must say.
Oh, okay. Is it the same in Oman and Malawi?
Yes, it is. Yeah, it is indeed, because we are one of the countries where we have high rates of mortality and morbidity with road traffic accidents. With this pandemic, of course, it's gone down much more.
Right. Okay. So that answers the question for the anonymous
We've not locked down, so the trauma rates haven't really gone down very much. But what's interesting is if you look at the South African figures, they have a negative rate of excess deaths. And in fact, the death rate in South Africa has gone down by 9% over the last few months. And that's presumably related to the fact that no alcohol is sold and that the amount of trauma has gone down significantly as well, despite the high numbers of corona cases.
Very interesting. Very interesting. In Oman and Sudan, I suspect the frequent religious gatherings and the recent festival of Eid must have been a real challenge. Are we going to take advantage of this challenge to put in measures in the mosques and these gathering areas for the future? Because this is a very sensitive issue. And I know that during Hajj, people who go from India invariably come back with a variety of infections which they catch during their stay there. Any thoughts on that from Faisal and Ahmed?
Yeah, I believe so. I mean, like once it is, it's still like since started, they started the lockdown when the mosques were closed. We haven't really started yet. But to add to that is more than, the mosques are closed for the last 5 months and 6 months. And it is the festivities which is the problem. So that's why the last festivities, the number of cases, the Eid al-Fitr, which is the end of Ramadan, the numbers went up actually because of these gatherings. That's why this time when this is the second Eid, which started just a few days ago, there has been a complete lockdown for 2 weeks, a strict lockdown. And from 7 o'clock at night in the evening till 6 o'clock in the morning, it's like a curfew. Like nobody goes out at all, for 2 weeks.
Right.
So and I believe like even after when they start the mosques to operate and everything, again, the social distancing and everything, the distance, as you know, the routine is that everybody is gathering all together like in lines and everything. So nowadays, of course, they will be making distance, like at least 1 meter or 2 meter distance between a worshipper and another also. I think that's what.
Ahmed, your experience, of course, you said that there is no social distancing in Sudan per se, but do you think this pandemic will change anything with the religious gatherings at all for the future?
Well, no. The short answer is no. In Eid al-Fitr, we're actually the other way around from Oman. When we had Eid al-Fitr after Ramadan 2 months ago, at that time everybody was scared. This Eid, last week, you should have seen the crowds. And in between, whenever a famous religious guy dies, you should see the amount of thousands of people coming to the funeral. None of this social distancing. You see, people here are so fatalistic. God will give us and he will take away. So we believe in him. And for the government, it's a very, as you mentioned, a very sensitive religious issue. You don't want to upset too many people. Sudan is in a state of political transition, let's say. We have a transitional government. And unfortunately, with the economic situation, nobody will really obey what the government says strictly.
Wow. Okay. Okay. Next question. Mitigation of COVID epidemic depends on the numbers of seriously ill staying low and not overwhelming the health system. Why have numbers stayed manageable in Africa, in the Middle East, unlike Europe and USA, despite less resources and less favorable social conditions? What do you think is the reason? Eric?
Well, it seems to be demography. Having a very youthful population for this particular virus seems to protect. That, I think that's the crux of it, and the comorbidities, etc., are far less common. So it is primarily, I would have thought, that.
Right, right. Ahmed, demography is the same in Sudan?
Yes, I would tend to agree with that. But, you know, the graph that I showed about which the message for me there was 10% of health is due to medical services. But then look at the other side, 25%, 36% is due to behavior, 25% is due to social environment, 22% is due to genetics. So I think we have not seen the end of this story. There are other factors. I tend to believe that, yes, demography, but then genetics, the environment around us, how does our heat here affect it? I think we have a lot to learn. And that's where my first slide, you know, I don't think the public health guys did a lot of research on the previous pandemics. We would have had some answers if they, or maybe I'm not well informed and I should look into their literature more, but surely something from the bubonic plague in London with those knife graphs, which are exactly the same as our COVID graphs, there must be some other factors that we should learn from.
See, it's very interesting you say that, because the guys in Hong Kong got on top of it fairly early, and that was because of their previous experience with SARS in Hong Kong, and they were able to contain it fairly quickly. But what is interesting is that there seem to be the second waves happening in various places. In fact, as of yesterday, the state of Victoria with Melbourne in Australia have gone into lockdown. So, you know, is this mutating? What is going on is still remains unanswered. Okay, I've got a cheeky question from the Director of Surgical Education. He says, we know necessity drives innovation. With less regulation in Africa and the Middle East, any innovations in treatment which has come to the fore, which the Western world can adopt?
Oman, okay.
Yes,
go ahead.
Faisal? Go for it, Faisal.
Yeah, I mean, in Oman, actually, I mean, we didn't come up with our own. Actually, we're just following the guidelines in the Western world. Actually, at some point, of course, they even bought almost 1 million tablets of hydroxychloroquine from India, but it was never used. Like, you know, when the research results came out. So, I mean, I would say, like, we don't have anything like innovative thing which came up. It's just like the usual treatment regimen which are used, taken from the Western, I mean, the WHO, basically. We are following the WHO guidelines, basically, a lot. Yeah. So,
right. Thank you. Ahmed, any local trials or any in Sudan?
No, to tell you the truth, this takes me away from COVID. I am also a health informatician, so I'm doing quite a lot of work in using mobiles for health. Now, there's quite a lot that is going on in that field. I'm afraid I cannot tell you about a lot of, because I have confidentiality agreements, but there's some very interesting things. But I don't know if they'll be useful in the West, because you see, we're looking at different problems. We're looking at access, improving access. We're looking at better follow-up for our patients, things that, and I can tell you this, with over 900 million mobile phones in Africa, there's a lot of potentialities. And by the way, for those who are interested, there's a huge NIH grant, $58 million for data science in health in Africa. We're quite active in that and looking at different things to do with it.
Thank you, brilliant. So the next question is, what has happened to undergraduate medical education? Does this impact on the supply of junior doctors in the next 1 to 2 years in your countries? Ahmed, if you can take that on.
Yeah, I'm quite active in this field. We did a huge study, about 25% of our students. We have 1 million university students in Sudan. So we did some sampling and did something about 3,000 of them. The students are ready for online teaching. The teachers are not. And for the teachers, the pedagogy is quite different. How to examine, how to teach is quite different. So we're now very active using Telegram and WhatsApp and all kinds of social media, teaching our teachers how you should really teach online. And I think, to tell you the truth, I think we are on top of it. We've just examined some of our students, and we're going to examine the rest of them after these are final year students. But my personal recommendation, and it hasn't been taken up yet, is we should catch students and graduate them. And for the rest, teachers need to learn what is the best teaching methodology to be done online. So this is my recommendation. For 1 year, no examination. We will be doing assessments, and there's different ways we can do that. But no, summative examinations. At the end of a year, we can do a final year examination instead of our current, every course we do an examination after. And that way we get the chance, and the students there will not be such a lot of resistance to change from either side, teachers or students. So, but it is the way forward, and I think we are late. We should have thought of this again from previous pandemics. How does life go on without being interrupted by catastrophes like these?
Thank you. The next question is to Faisal. What sanctions are being used in Oman at the present time for people who do not observe lockdown?
Yeah, I mean, there are hefty fines actually by the police. If somebody is not wearing the mask, it used to be like 20 riyals fine, which is around, $40 or $50, something like that. And then now it's been increased to even 100 riyals actually. And those who are making any gatherings, who organizes the gathering, he will be paying, I think the fine is almost 1,000 riyal or something like that. So there are really big fines for.
I see. Right. So the final question which I'm going to ask is, Ahmed, what role has epigenetics upon mortality in Sudan?
We don't know because we haven't been doing. We don't have the cases. We love to look at. I mean, as a cardiothoracic surgeon, I wanted to look at the role of ACE inhibitors. And ACE inhibitors are not good blood pressure medication in Black Africans. We know this for a fact. So theoretically, we should not be having too much ACE expression. And there's something in our genes. And that's maybe the reason why we don't have enough COVID. But unfortunately, we don't have the resources to do that. We're looking at how we can collaborate with other countries, and we're selling this idea around. But I take you back. You remember the COVIDOR study that we did? We have a basic problem. We could not get ethical approval from 8 of the countries in Africa that we wanted to ask a simple online survey. So we have a lot of things that we should have learned and we should do better in before we get complicated.
Thank you very much. I just want to conclude by saying that it appears as though all of us are looking at new ways of delivering education, new ways of delivering examinations, and clearly after this discussion, it will be a great collaborative process that all the fellows of the college all over the world can bring together. What we have done during this lockdown period from the college is to develop a preparatory course, which we have piloted in the college in the first instance. And once we felt that it was satisfactory to go ahead, We then ran this course in Malta with excellent feedback. And we're now trying to see if we can use this platform around the world. So watch this space. And gentlemen, I would like to personally thank you ever so much for such a wonderful evening. I'm sure that we have learned a lot. We've had almost 100 participants, and the question box was quite full. And I think we managed to answer most questions. But if there are any questions which remain unanswered, I'll deal with this through the YouTube channel that we will post this in due course. So Eric, Ahmed, and Faisal, thank you ever so much on behalf of the college. Thank you.
Thank you. Thank you. It's been a pleasure.
Bye-bye.
Take care.
Thank you very much, and stay safe.